Other considerations to remember, so these echo sessions are interactive learning communities. So we definitely encourage everyone to leave their webcam on and have a microphone available when possible. There will be breakout group sessions after the family story today. And so we just encourage everyone to be able to participate fully and to have those things available at that time. Also, definitely use the chat throughout the presentation. If you need assistance or have any questions, we're definitely more than willing to help out there. Finally, and again, I know a lot of folks have probably been to a few of these already, but something to remind you all of, if you're, please rename your profile in Zoom to your first and last name, as well as the organization that you represent. That, again, that just gives us a sense of where we're reaching folks and gives a little bit of introduction without having to put it all in chat. So you can just hover over your name, click the three little dots, click rename, and then type in your name like the example. Now I'd like to introduce Dr. Jennifer Howlandy. Dr. Howlandy is a researcher and psychologist with a specialty in early identification of developmental delays and disabilities. She leads the Autism and Developmental Disabilities Monitoring Network and the Minnesota Act Early Project. She's also faculty in our Minnesota LEND, or Leadership Education Neurodevelopmental Disability Program. Join me in welcoming Jennifer Howlandy.
Thank you, Drake. Nice job. This was the first day of doing this, and you did a great job stepping into Courtney's shoes, so thank you. Welcome, everyone. It is so good to see all of you. It is a beautiful day in Minneapolis today. I'm not sure what it's like where you are, but almost a top 10 weather day, I think, here. That said, you should stay for the content. You can go outside if you need to, but it will be engaging and worth being inside, or take your laptop outside. Thanks again, Drake, for the nice introduction. I'll just be really quick with our project scope. We always sort of do a little housekeeping first because we want to get to the important part of the presentation. We are Project Scope. It stands for Supporting Children of the Opioid Epidemic. We focus on neonatal abstinence syndrome, known as NAS, or Neonatal Opioid Withdrawal Syndrome, NOWS, which I believe is the newer, more accepted terminology. We are a community of early intervention providers supporting children and families. Fran was asking a little bit earlier who our audience is. We're all over Minnesota, and we use the ECHO virtual training model. Next slide, please, Drake. And ECHO stands for Extension for Community Health Outcomes. It's a long-standing model to promote health equity and connect people. We go beyond geography here. We don't let geography limit us. Hence, we're virtual, we're online, more accessible. We work to increase access and decrease disparities in our communities, and we really want to bridge health and education, and we're a community of practice together. It's so fun for all of us to see familiar faces, log in. We get to know each other during our family study time, so we just really appreciate you spending the afternoon with us. Next slide. And then the key components of the ECHO model are technology. We use best practices to reduce disparity. We always have a family story where we apply our learning, and we use data to monitor outcomes. That's the survey that you get after this. So today is session 6. We're going to be doing a deeper dive into neonatal abstinence syndrome and neonatal opioid withdrawal syndrome. I will say, Dr. Prekker, we are so happy to have you. We sort of pieced this together in terms of schedule availability. We've had some that did a little bit of a deeper dive. Yours is going to be a great overview, and we're very excited about the content. I think our participants might be wondering a little bit, okay, this would have been great first or second, but now we actually have a frame of reference we can apply this to. So we're super excited. And Dr. Prekker is going to talk from 3:05 to about 3:40. We'll do our family story, breakout groups, and then closing remarks and get you out promptly at 4 o'clock. Next slide, please. So I am going to introduce Dr. Fran Prekker. We're so happy to have her here. And I have your nice bio here. So if it looks like I'm reading it, it's because I am, and you have a lot of great experience. But Dr. Frances Prekker is a pediatrician working at Hennepin Healthcare. She received her MD from the University of Minnesota, go Gophers, and then stayed to complete both her residency and chief residency in pediatrics there. She's been working as a pediatric and newborn hospitalist since 2011 and is board certified in both general pediatrics and pediatric hospital medicine. Since 2014, she's been the medical director of both the newborn nursery and the pediatric inpatient unit at Hennepin County Medical Center. Dr. Prekker has special interest in care of substance-exposed newborns, perinatal substance abuse, and care that preserves the maternal child newborn dyad. She's led many quality improvement projects at HCMC around improving care for infants experiencing withdrawal, keeping moms and babies rooming in together, and reducing bias in newborn drug testing. She enjoys teaching families and learners about caring for newborns. Welcome, Dr. Prekker. We're so happy to have you here today, and we're excited for you to share about your experiences and knowledge.
Thank you so much for having me. It's really exciting to get to talk to the rest of the people who are caring for these children after they leave the hospital and as they are growing and developing. It's great to connect with everybody. Like I said, I'm Fran Prekker. I'm a pediatrician. I am not a neonatologist, which is just, it says neonatologist on the other screen, but I don't actually care for babies in the NICU. I'm caring for normal, generally healthy, well newborns, and those are sort of my very favorite patients. I did get the wrong date on this, so you have to excuse the error on my slide here. We have not jumped ahead a week. I just got confused.
All right. Thanks, Dr. Prekker. We were worried.
Next slide.
Next summer here.
All right, so I have some objectives for the talk today that you can look over, and I have nothing to disclose. Next slide. So I think important to talk a little bit about limitations, both my own personal limitations and the limitations of our understanding of this topic. So I have a lot of clinical experience and a lot of personal interest, and I have read a lot about this topic, but I also admit that there are things that I probably will tell you today that might be an error or a misreading of information. And also there are a lot of gaps and limitations of the literature in this topic area around opioid exposed newborns and substance exposed newborns, especially when we start talking about their longer term outcomes. There is a lot of inconsistencies around how different terms are used, how different populations are defined, what we are controlling for, which confounding factors we are going to control for in different studies. So hard to generalize and hard to get a really complete picture of this topic. And I'm sure that there are things that I will tell you today that several years from now, we're going to be understanding in a different way. So just know that nothing here is set in stone. All right, next slide. All right, I think it's helpful to talk about a couple of the terms that you'll hear used and define how we would like to think about them. So an opioid exposed newborn, or later we'll talk about opioid exposed children. For that, we're talking about prenatal exposure to chronic or habitual opioids. We're not talking about a mom or a baby who was exposed to, 3 doses of oxycodone during pregnancy. We're generally talking about more consistent and habitual exposure. And the exposure can be any type of opioid. So it could be illicit fentanyl, or it could be the maintenance methadone that we prescribed for mom for her opioid use disorder during pregnancy. So that is opioid exposed newborn. The next term is Neonatal Abstinence Syndrome, or NOWS, and you'll hear this one frequently. This is a term that was coined in the 1970s as pediatricians were looking at the clinical syndromes that they were seeing in newborns after mom had been using heroin during pregnancy. And so that's when people started using this term. In the intervening decades, it got generalized out to sometimes describe children who are or infants that were experiencing withdrawal symptoms from other substances. So other illicit substances or nicotine. Some people would use the term neonatal abstinence syndrome to describe the sort of the clinical syndrome that those babies presented with, which can make things really difficult to understand what is the common thread in that population. So in the last probably 5 to 7 years, we've had a switch in the literature to going to using the term neonatal opioid withdrawal syndrome to be more specific. So when you're talking about infants who are experiencing neonatal opioid withdrawal, they all have an opioid exposure and you are seeing withdrawal symptoms in them. Interestingly, many of the infants who fall into the neonatal opioid withdrawal syndrome bucket will also have polysubstance exposure. So just because they have opioid exposure doesn't mean that that's their only exposure. They may have other substances that they were exposed to as well, but definitely they were exposed to an opioid. I think as you think about these populations of, kids that you could call neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, you can start to imagine the heterogeneity of this population. So not all these infants have been exposed to the same medication or opioid or the same dose or frequency, and the other substances that they may have been exposed to are also quite variable. So it's a quite heterogeneous population of infants, which makes studying them challenging. Next slide, please. So I know you guys are all very well aware of the opioid epidemic in the United States. And as we had increased opioid use in adults, some of those adults are pregnant people. So the rates of opioid use in pregnancy have definitely gone up as well. And once we have pregnant people who are using opioids, we know that we have more perinatal exposure to the fetus and then more infants who are opioid exposed. So the rates of neonatal abstinence syndrome, which is still the term that the state of Minnesota is using for these babies, has definitely increased over time. In 2008, there was 1 infant with neonatal abstinence syndrome per 1,000 live births in the state of Minnesota. And by 2019, we're up to over 10 per 1,000 live births. And that distribution of babies across the state is not uniform. So there are certain areas in the state that are much harder hit by this diagnoses than others. So the northeast corner of the state, the rate of neonatal abstinence syndrome up there in 2019 was about 35 per 1,000 live births. So way more per population in certain areas of the state than the others. All right, next slide.
I'm sorry to interrupt. Did you say 35 per 1,000 live births?
Per 1,000 live births.
Wow.
Yeah, and so if you think about, the population density up there, some of the rural areas of the state are much harder hit with this. So absolute numbers, we still have more infants in the Twin Cities than outstate, but sort of the impact to the healthcare system and to the population is much higher in rural areas of the state. So as we look at people who are using opioids during pregnancy, I think it's helpful to look at some of the other demographics and characteristics of that population. And as you can look at this list of differences between a pregnant person who's using opioids in pregnancy and someone who is not, you can see some key differences and key comorbidities, many of which are also associated with poor childhood and infant outcomes. So important to know that that opioid use in pregnancy also go hand in hand frequently with other risk factors for poorer childhood outcomes. Next slide. So how do we get to this point? I think we've kind of alluded to it, and you guys probably have heard this from other speakers. But when a person takes opioids during pregnancy, the opioids freely cross across the placenta and get to the fetus. And so after habitual or consistent exposure to opioids, the fetus experiences physiologic changes that then at birth, once that opioid exposure is stopped, those babies can experience withdrawal because they are born with physiologic dependence on an opioid. I think helpful to sort of think about the terminology that we use for babies who are born after opioid exposure is that they are physiologically dependent on an opioid, but they are not born addicted. Addiction is a whole nother thing that there's no way for a newborn baby to be addicted to a substance. So the clinical syndrome that we see is the downstream effect of these physiologic changes from prolonged opioid exposure, and then the withdrawal from that. Next slide. So when we have a baby who we know is opioid exposed, we would love to be able to have a crystal ball and know exactly what that withdrawal process is going to look like for each baby so we can predict and help. But it's impossible to know at birth exactly what their withdrawal process is going to look like. There are some maternal and newborn factors that do tend to increase the severity of withdrawal in the baby, and you can see those listed on the slide. Interestingly, the dose of maternal medication does not seem to be really well correlated with the severity. So we'd love to look at a mom and say, okay, you're on this dose of methadone, that means your baby's going to have severe withdrawal versus if you were on a lower dose of medication, but the correlation is just not there. So we monitor all of these infants and we treat the withdrawal symptoms as they show us that they're having withdrawal. All right, next slide, please. All right, so thinking about what does this look like at the bedside for a newborn baby? Most of the symptoms that they are going to have fall into one of three categories, either neurodevelopmental, gastrointestinal, or autonomic. And really, you know, looking at a baby at the bedside, you're often going to have a very fussy, easily overstimulated infant with very high tone or some tremors, and often having really disrupted sleep and poor eating. So you can imagine that sounds like a really challenging newborn, and these kids can be really difficult to care for and be super high needs, challenging newborns. Next slide. So once we have a baby and we know that they are opioid exposed, there are a number of different assessment tools that we can use to help us determine the severity of their symptoms and help guide our management. The score on the left is a score that's one of the original scoring tools is called the Finnegan score. It was developed in the 1970s. As pediatricians were looking at the experience that babies were having after withdrawing from heroin and later from methadone. So this is kind of a laundry list of many, many symptoms that a baby can have as they're experiencing withdrawal. Many of these are not specific at all to withdrawal. This is likely still the most popular, widespread used tool for assessment of withdrawal in newborns. The tool on the right there is called Eat, Sleep, and Console. And this was developed within the last 10 years by Dr. Grossman out at Yale. And this has, in the last several years, gained a lot in popularity because of its relative ease of use and its association with some short-term better outcomes for newborns. So less medication use, shorter lengths of stay, more infants together with mom. So this Eat, Sleep, and Console is definitely up and coming. I think that as you think about assessment tools in the hospital, it's important to choose one. And there are many out there to choose. All of them have some benefits and some limitations. And I think that it's important to train your staff to use whichever tool you have, train them to use it well and use it consistently. And that may be more important than exactly which tool you use. Next slide, please. So in 2012, the American Academy of Pediatrics put out a position statement on neonatal withdrawal. And this is one of the sort of goals of therapy that they have for newborns who are experiencing withdrawal. And I think that this is really a nice framing of what are we trying to go for in the hospital. And it's often not a baby who is going to look exactly like their non-opioid exposed peer. It's a baby who is able to do enough of their regular stuff and begin to engage socially with family. Next slide. So as we care for these infants in the hospital, I think it's really important to sort of change from sort of our traditional model, which was caring for a baby separated from mom in a NICU-like environment, to trying to do this more as an infant and family-centered care and focusing very much on trying to care for the dyad together, because more and more studies are showing that babies do better and experience less withdrawal if they are with an engaged caregiver. So you've kind of got the infant there in the middle. I think studies do support that having an engaged caregiver, often a mother who's rooming in with the baby during the hospitalization, will decrease the severity of withdrawal, decrease the amount of medication used to ease withdrawal symptoms, and shorten the length of birth hospitalization. So I think that figuring out how to alter our hospital care models to support rooming in during the entirety of infant stay is really important. This is not something that many hospitals traditionally have been well set up to do. So it's been a shift for all of us and has definitely taken a lot of work. The environment of care is also quite important. If you imagine a very easily overstimulated newborn, you want them to be in a low stimulation environment. So usually this is a room with mom that is quiet, not a lot of visitors, dim lights, not coming in to bother the baby every hour. So as low stimulation environment as you can get. Supportive cares. These are often very as simple as giving the baby something to suck on, swaddling the baby, gentle movements, not sort of big, loud bouncing the baby, but a little bit more gentle handling of the baby, and definitely respecting their sleep. So these are babies that if they are sleeping, we are not going to go interrupt them to take a temperature or a random vital sign. We are going to wait until they wake up, and then we're going to cluster our cares so that we're not interrupting sleep for these kids. Nutrition is also essential. Babies who are opioid exposed are at risk for having excessive weight loss right after birth and for poor feeding. During the sort of the acute withdrawal process, many of these children are extremely hypertonic and so use a lot of calories. So they need a lot of calories. We do support breastfeeding in a lot of these women, and breastfeeding is associated with improved outcomes for these babies. So when it is reasonable to do so, we certainly encourage and support breastfeeding. And then we'll get to medication in a sec. Next slide.
Francis?
Yeah.
Someone had a quick question. I meant to say Rebecca and I will monitor the chat.
Oh, okay.
Jody asked, related to what you just shared, how does rooming in work at HEMC for moms who are also going through treatment?
It's a great question, and it's changed over the last 10 years. So often now, so mom and baby are rooming in together down in the birth center. And then baby stays in the hospital after delivery for at least 3 to 5 days minimum as we monitor for withdrawal. Usually mom is ready to be discharged before then. So oftentimes what we do is move the entire dyad up to the pediatric unit where they continue to room in together until baby is ready to be discharged. We have tried to work closely with the treatment facilities to support mom remaining in the hospital until the baby is ready to go. Sometimes this looks like mom being there at nighttime, but at the treatment facility during the daytime. Sometimes they'll give mom, hey, that's okay. You will spend an extra week in the hospital with your baby and then come back to treatment. It seems to be kind of a case by case working with the treatment facilities to figure out what's going to be best. But we definitely try to encourage mom to engage in the care of the baby in the hospital for as long as possible, because it definitely helps.
Thank you. And there's one more question from Sarah. Is there a concern for the substance to come through the breast milk? I assume the benefits from connection and breast milk outweigh that.
So I think that it depends on what substances, and I was deliberately a little bit vague about this. So there are some moms who have ongoing illicit substance use that we do not encourage them to breastfeed because of the concern around substance exposure through the breast milk and or other things that you might be exposed to through the breast milk. So for many moms with ongoing illicit use, we recommend against breastfeeding. For moms who are stable on methadone or buprenorphine, then we definitely do recommend breastfeeding. Probably not enough of the medication comes through the breast milk to be particularly harmful to the baby or really help with their withdrawal symptoms. But the bonding and all of the other benefits of breastfeeding are definitely there. And there are good studies showing improvement of baby symptoms and length of stay and medication use when there's breastfeeding. All right, I think that we can all agree that this is important. Baby is not in isolation. This is a dyad that we're generally caring for, and we are trying to empower mom to care for her baby rather than have her watch us care for her baby. And supporting her, as we highlighted before, these can often be really challenging babies to care for, and trying to make sure that we're supporting mom and that she gets the respite and rest that she needs, and that she has the support that she needs to go get through this experience successfully. Many moms who have had substance use in pregnancy have a great amount of guilt around what watching their baby go through this process. They know that this doesn't feel good. They feel sad and guilty around what their baby is going through. I think that as we can create as supportive, non-judgmental spaces and care as possible is really important. I think this is also a good place to note that using person-first, non-stigmatizing language is really important as we approach these dyads. Next slide. All right, medication. We can't have a talk about neonatal abstinence or withdrawal without talking about medication. So it definitely is a tool in our toolbox. We are trying to use it, I think, less than we used to, because there are some risks of using it, including prolonged separation from a caregiver, prolonged hospitalization, and a lot of postnatal opioid exposure. this varies greatly institution to institution. Even within units of the same hospital, this can be approached in different ways. I think there is no absolute consensus on how we should be approaching medication or when we should be using medication. I think we can agree that if you are experiencing severe opioid withdrawal, you should treat that with an opioid, not with other medications. And there are several different choices of which opioid is used to treat a baby experiencing severe withdrawal. It seems in the literature more recently that having a standard protocol around how we're going to treat a baby matters more than exactly which medication you're using. And there's a lot of changes that we've made in the last 10 years around this and how we approach medication use in these babies. Next slide. All right, so I think that, you know, as we think about the hospital, this acute withdrawal period is self-limited. It will not go on forever, even when it feels like it is going on forever, and that we need to be really judicious about when we're choosing to use medication because we don't have a complete understanding yet of the risks and benefits of that are associated with all of the medications that we might be using. All right, next slide. All right, so by the time we're talking about discharging a patient, discharging a newborn with opioid withdrawal, there are already things that separate that newborn from a non-opioid exposed newborn. And some of these experiences that they have had and the disruption in maternal infant bonding and some of the other comorbidities can certainly impact their long-term development and their long-term outcomes. So even by time of discharge, these babies are set up, have a different setup than their non-opioid exposed counterpart. Next slide. All right, so I'm a hospitalist. For many of my patients, I view discharge as the ultimate goal, a safe discharge, safe, healthy discharge as the ultimate goal, but recognizing that my part of things in the hospital here is only the end of the beginning. And so it's like the foothills of the mountain for these children. By the time baby with opioid exposure goes home, they are likely to still be having some symptoms of withdrawal. And those symptoms may go on for weeks or even months and be things like irritability, dysregulated sleep, poor feeding, or easily overstimulated. So these kids may go home and still be really challenging newborns to care for, and that can go on for months. Next slide. So as we think about sort of the out of the hospital and what next and what happens with these children, I think that this literature, it gets even trickier. And some of this is definitely in the realm of many of you more than me, as it is about their developmental outcomes and the concerns that there are around that. This is really tricky literature, I find, because of all of the confounding factors and the comorbidities that go along with this. So it's hard to tease out exactly what is the substance itself, the substance exposure itself, and what is everything else that that child may have gone through. So I'm going to go through a series of things that are probably related to in utero opioid use, and we'll talk about some of the things that we should be watching out for these babies longer term. Next slide. So visual conditions. This seems to be pretty consistent in the literature that these children are at increased risk for some visual problems. This was actually kind of news to me as I was reviewing some more literature for this talk, because of course I'm seeing them mostly in the hospital. But pretty consistently through the literature, there are significantly increased risks of certain types of visual problems. So strabismus is that misalignment. Nystagmus is usually a bouncing or abnormal movement of the eyes, and refractive error is just that they're not focusing well. So you can see that kids who were opioid exposed and especially kids who were treated for opioid withdrawal with medication were at significantly increased risk of visual conditions. So something to keep an eye on. Next slide. Motor development. This was a little bit less clear, although certainly there are studies with concerns for motor deficits out through, I could find about early school age. I didn't really find much in the literature to talk about motor deficits after that early childhood period, but certainly this is something that we should be keeping an eye on. And I think that we know from other general developmental literature that motor deficits may not be occurring in isolation. They can certainly go along with other kinds of deficits. Next slide. It appears that there is an increased mortality risk for these infants in the first 12 months of life. This has been demonstrated in several different areas. So there was a large Australian study and one here in the United States that demonstrated this. There have been some other studies that if you correct for enough factors that this gap goes away. But I do think that this is probably real, although it's hard to estimate exactly how large this mortality gap is. And it appears to be mostly sleep related. So it seems that there is an increased risk of sleep related death in infants who are opioid exposed. Next slide. It appears through several different studies, including some in the United States and some in Australia, that they have an increased risk of readmission to the hospital within the first 12 months of life, at least the first 12 months of life, and that there are some fundamentally different aspects of the care of the need in the hospital. So these are usually longer hospitalizations, higher risk of ICU readmission, and higher risk of intubation. And interestingly, this is from a US study. They found that the causes of readmission to the hospital were kind of fundamentally different in kids who are opioid exposed, with more admissions for injury and trauma. So I thought that that was interesting, although if you look at the absolute values there, or the percentage, we're at about 6% readmitted for injury, unintentional injury for infants with NOWS, versus we kind of just barely get down to 6% on that list of infants without NOWS. So I'd like to get out to, number 10 and see exactly how different these are. The Australian study also does find a difference in readmissions for injury out to about adolescence. So that is probably real. Next slide. Cognitive outcomes. This is even more confusing. This probably makes more sense to you guys than it does to me. This was really hard to interpret for me, but I think that this is probably something that is real as well, though difficult exactly to characterize based on the different outcomes that people are using in studies. So a number of studies that look at different outcomes, many of which found deficits or differences between opioid exposed children and non-opioid exposed children. I think that the Tennessee study was interesting, as it looked for the rates of referral for educational disability and assessment in kids with opioid exposure was higher than those without. Although there was this study, it's called the Mother Study, that looked at about 100 opioid exposed newborns and followed them out, and that they did not find any cognitive differences by 36 months. Although it does seem like that study was associated with a lot of enrichment and engagement with providers, which may have ameliorated some of the differences. All right, next slide.
Just so you know, you're at 3:40, so just like a
Oh,
1 or
goodness.
2 more
Okay.
minutes, just so you know.
Okay, yep.
Yeah, you can.
There's so much to say. Okay, all right, behavioral health. Many risks here, although it's hard to say what is associated with opioid exposure and what is the everything else that these children may be experiencing. Next slide. Here is some of the other everything else that these children may be experiencing that may certainly be affecting their outcomes. I thought that, you know, these kids are much more likely to be engaged in the child welfare system, have out-of-home placements. I thought that this study, it was the bottom point there is a study where mothers who were engaged in an opioid use program were self-reporting the experiences of their children and the things that their children had experienced. And I just thought that, you know, based on a self-report of a mother, the number of these children that have experienced really, really traumatic other things is extremely high. Next slide. All right, so here's the bottom line. Like, there's so much risk here for this population of children, not just based on the substance that they were exposed to in utero, but everything else that may go along with that. And so the hopeful thing that I kept finding in these studies as I was looking at the longer term outcome is that it seems like there are factors that can mitigate some of these risks. So having stable home and family environment, having an enriched environment, improving a family's socioeconomic status seems to have positive effects. And so I think that, you know, this is the reason that we're all here, is trying to figure out what of these risks, how can we intervene to have these children reach the highest potential that they can, and to support these families through these challenging these challenges. So that's sort of where I came to is, yes, there's a lot of risk, but it is not hopeless. And there are many areas where we have opportunity to help things be better for these kids. So, okay, done. All right, 3:43, just a little bit late.
Nice, right. Dr. Prekker, really, that was loaded with excellent information. You may have noted our last series, this was an hour and a half, and now we cut it down an hour. So your time goes so quickly, but you did a beautiful job. I have to agree, your presentation and mine sort of intersected a little bit in a nice way. And I agree that the research is important, but messy. It's very hard to disentangle all the multiple risk factors in the lives of children, particularly those who've been exposed to opioids. And I thought you did a really nice job explaining that.
Yeah, I would love to see your presentation as well to understand, because, you know, I wanted to have some more of this longer term outcome, because that's what you guys are here for, but it's also not, it is really difficult literature for me to understand, and it's very messy.
I absolutely agree. I'm happy to share. And I was very happy to see on your last slide, early intervention is on there as one of likely the key contributors to mitigating some of the risk factors, which is the population we have here today are people that deliver early intervention services. So your work is important. If you didn't know before, another validation how important your work is with children and families. There's a couple more questions, Dr. Prekker, and I'm going to read them to you. Okay. Jody has a question. Because of the complication of multiple delays for these babies, I think about the potential need for parents to be supported and engaged in learning. How are you helping these parents to get connected to parent support upon discharge?
That is really challenging, and I wish that I could say that we are doing better, because I think that this is really hard, finding the right support environment, the right, you know, it would be lovely to have more peer support for these families as they're experiencing these challenges together. We are trying to get better about making referrals to early intervention services and other kinds of support programs, and making sure that mom has kind of her own independent of the child mental health or chemical health support. But this is not perfect. And if you have suggestions or organizations that are doing this well, I would love to learn from them, because I feel like I can do a great job while they're here, and it feels like not enough support as I send them out of the hospital.
Absolutely. Dr. Prekker, I just have one additional thing to add, and it's more on a policy level. We did talk in our last series about perhaps NOWS being an auto qualifier for Part C for early intervention, similar to the way that Down syndrome or other disabilities are. And some states have done work in that arena. And so there's that better link between the connection between the hospital and getting that family in right away. They also then, of course, those states have done some work in terms of getting, while they're there to serve the child, connecting the family to supports and services they need as well. It's just one sort of policy innovation we've seen in other states.
Yes, I think that would be great. I think that, you know, internally here, there are definitely most of the babies that get medication to treat their withdrawal in the hospital. We have our occupational therapists and our speech therapists see them here while in the hospital. Oftentimes they're following up with their occupational therapist within, you know, the first couple of months to see how development is. But it's not really the same kind of wraparound services that you're talking about with early intervention to longitudinally follow those kids outside of the hospital. So I think that is really great.
Yeah, great. Well, I would love to chat more. This is such a fascinating topic. There are so many policy innovations we could pursue. Perhaps this group would like to connect on that. But I know we have our family story coming up. But Dr. Prekker, thank you so much. That was wonderful, a wealth of information. And thank you for the work that you do as well. We appreciate it. And I'm assuming, is it okay if people contact you if they have any additional questions?
Absolutely. Yep.
Can you just put your email in the chat? And I know there's other questions, but we just so appreciate, I think we need to do more of this in our field of linking medical and education and working together on behalf of these children and families. So thank you, Dr. Prekker.
Thanks for having me.
Thank you, Dr. Prekker. And Jen, I'll just jump into the family story since we're short on time, but thank you so much for coming, Dr. Prekker. The family story today is about a recent Afghani family that's a refugee status coming to Minnesota. As you know, we have been welcoming a lot of Afghani refugees of late. And so this family in particular, I'm sorry, I'm trying to find my slides. This family in particular has been settled in Hopkins, Minnesota, a population of 18,400. It is a first-ring suburb of the Minneapolis area. They've settled into a 3-bedroom condominium and are in month 3 of their 6 months of the free rental payment agreement we have for refugees. They had spent 3 months at a Bloomington hotel as they waited for housing. And it's an extended family. Next slide, please. The background of the family story is the mom, Rena, is 40 years old and has just given birth to her 6th child who was born with NAS or NOWS. And Rena has smoked heroin in her home country for back pain and obtained recent pharmaceutical opioids for pain in the US upon her arrival. And Rena is resisting center-based MAT because she's not willing to leave her family or her home. This is the first time for Rena to even hear of the Western diagnosis of NOWS. Next slide, please. And the strengths of the family are that they're a large extended family, including an uncle and some aunts who can help care for the 6 children who are all under 8. Rena is a dedicated mother. And the family is starting to acclimate, and Rena's husband just got a job as a security guard. The challenges and barriers are the entire family has endured trauma in their escape with the fall of Afghanistan to the Taliban. And the second youngest boy was recently diagnosed with selective mutism, often connected to post-traumatic stress disorder. And Rena is, as we said, resisting a center-based MAT and is still obtaining opioids from a doctor. All right, and I believe Jen has put those into chat. I hope.
Yes, I have. I have
Awesome.
done, and I'm doing the last one right now.
All right. And then the breakout question is very simple today, and we'll probably have time for a 7-minute, 6-minute, maybe 6-minute breakout, very short. But our question is, how can we best support Rena and her extended family, including her 6 children? I forgot one detail that likely all of her children had NAS, but this is the first time for it to have a formal meaning for her. All right.